for coming today. So, I mean, just like a quick background to this organizing this meeting. So the CCG did some work over the last couple of years on the data on diabetes in general in Wigan Borough. And one of the things that was highlighted was our uptake of urine ACR screening was very low. There's some, I don't know whether you got the email last month from the CCG, but I think overall uptake of ACR screening was about 30% for Wigan Borough in general. Thankfully, this has gone up slightly this year to about, I think the average is still about 40%. So we thought like an education meeting just to update on the importance of why we should be doing urine ACR, at least on an annual basis in diabetic patients is important. I think part of the problem was COVID, patients were not coming to the surgery, so we're probably not giving them those urine pots and stuff like that. So hopefully with some education and also increased awareness, we can get this figure much higher than what they are at the moment. So I'll pass on to Professor Kalra to give us a talk on the subject.
Thank you very much. And you've just hit on probably the main thing that I wanted to emphasize in my talk actually is absolutely all about what you've just mentioned there, ACR testing. Right, I'm going to share screen. Let's see, make sure this works. Good. And can you all see? So I won't be able to see you when I do this, okay? Can you all see my screen now? I'm going to go on to slide view, okay? So slide presenter view, there we are. And I'll just need to move this off the screen at the top right. There we are. Oh, what have I done? Just close that. Right, you can see me quite happily? Yeah.
Yeah.
I'm just moving. There we are. Right, so yeah, management of diabetic kidney disease, that's our shiny new hospital. It's now 10 years old, that new bit to the front. Had to wait a long time for that. So I've worked as a consultant in Salford for 27 years, as of the 1st of July, actually. So one of the old guys. So, but I'm also the R&I director for the trust, which is so that's research and innovation. So that's our trust is now, as you probably know, we've got Rochdale, Alderman, Bury, as well as Salford in ours. So let me just move this on. Right. So just a few facts and figures. So economic burden of diabetic kidney disease is massive in the UK. So these are figures from well over a decade ago, when our budget in the NHS was probably about 100 billion. I think that's gone up now to about 160 billion, hasn't it, with recent changes, ploys by the different, governmental parties over the years. But the point here is that if we look at the patients who actually end up with end-stage kidney failure and needing dialysis, they are a huge cost. So this 1.5 billion from 2009-10 is probably at least 2 billion now for CKD, and we think that dialysis and kidney transplantation is over half of that. So it's £1 billion a year, is what we pay. So I'll just give you a few examples. So a hemodialysis patient costs us £35,000 a year to treat. Peritoneal dialysis, 20,000, something like that, and a transplant. First year costs are high, obviously the operation and everything, high drug costs initially, but then that settles down. So high first year costs, maybe up to 20,000, but thereafter less than 10,000. And there's no doubt that transplantation is the way to go for end-stage kidney disease. And you've all heard of initiatives like Transplant First. It's a big NHS initiative trying to, where a person has got a transplant donor to try and get that done first. Okay, so the message from this slide is let's try and avoid end-stage kidney failure. So that means intervening early, and it's back to what Anup said about testing. So here we go, and this to me is probably one of the most important slides I'm going to show you. So here it demonstrates, if you follow the blue line, this is GFR, and you can see that if we waited till we get down to a GFR of 60, which is the start of, just below that is stage 3 CKD, to diagnose CKD, if we did nothing until then by that time we'll have lost something like 3/4 of the functioning mass of the kidneys. Really important point, okay? However, if we are quick off the blocks and spot when the ACR becomes above 3 milligrams per millimole, the urine ACR, then at that point, we'll have only lost 20 to 25% of functioning mass. So ACR is picking people up at a much earlier stage in diabetic kidney disease. That's a key point. Overall, I have to say this, of all type 2 diabetics, again, type 2 and type 1, obviously 90% of the diabetic kidney patients we see are type 2, which manifests, you know, what we see in the general population. 90% are type 2, aren't they? So essentially, it's ACR 3 or worse in those patients. Get it as quickly as possible. And again, this is backing up what you just said before, Anna. This is national data. Look, the National Chronic Kidney Disease Audit from 2017, and it shows that in diabetes, obviously this is pre-pandemic, they're pretty good for annual testing of kidney function. 85% of patients with diabetes got a test, but only 55% actually had urine ACR tested, and that's pre-pandemic. And the figures you just quoted before are worse than that, aren't they? You said 30% improving to 40%. So you know, we want to see, why can't it be, you know, 90% of patients? Why not? So I'm going to emphasize something about the worry about early morning urines in a second. I'll come on to that. The other thing to say is that diabetes obviously is a risky area. The patients are at risk of cardiovascular disease because, as well as what we call the microvascular complications, which are renal, you know, retinopathy, neuropathy, we have the macrovascular complications, don't we? And those are obviously MI, peripheral vascular disease, stroke, etc. Okay, and this here is 10-year risk. So divide these numbers by 10. So the 10-year mortality of type 2 diabetics, sorry, the annual mortality is about 1.2% compared to 0.7% in age-matched controls. And you can see that as we go from just diabetes to diabetes with albumin, diabetes with impaired GFR, and then with both albuminuria and impaired GFR, you can see that that accelerates from 1.2% per year to a 5.5% annual mortality. So 1 in 20 of those patients are dying every year. Okay, so a really, really important point. And that's because obviously the advancing albuminuria and low GFR in a type 2 diabetic is telling us that the large blood vessel disease is also advancing in parallel with it. Okay, big risk. I just want to show you this as well. Something else about, well, you think, well, okay, so they get onto dialysis, they're going to be all right because we'll keep them alive. Well, unfortunately, it's not great. This is data over 20 odd years, looking at women and men and comparing dialysis, which is orange, against some of the commoner cancers. And you can see that we have not changed the survival likelihood of patients over 2 to 3 decades in men or women, whereas with colorectal cancer, breast or prostate cancer, you know, there have been improvements, haven't there, in terms of the outcomes of those patients. So, you know, people with breast cancer and prostate cancer, we're looking at a 70% survival probability over 10 years compared to just 30% for dialysis patients. I'll put that into another, give you another figure. So in, you know, Salford, we've got 600 dialysis patients. Obviously, we have a Wigan dialysis unit, Bolton, Rochdale and Oldham, as well as Salford. But taking all together, we have a 14% annual mortality on the dialysis program. Now, obviously, there's a lot of old people there, but you know, the condition itself on dialysis, it's not like being transplanted. So these people have got, you know, a really bad outcome. 1 in 7 will die every year. So we now have new nice guidance for CKD. And I think one of the things you wanted me to briefly talk about is, when do you start looking for CKD and when do we refer patients in? So this is the NICE guidance for CKD came out in August 2021, and there are some additions to it. I'll just tell you about in a second. But this is not new to you. This is what you've been using for the last decade or more. You know, estimate GFR using the CKD-EPI equation. Well, you've got no control over that. It's whatever comes out of is spewed out of your lab. Sadly, Salford is still using the old equation, which is the MDRD equation. But anyway, it will change. And then test ACR. So here we go, urine ACR. And it says there, ideally in an early morning sample. So I just want to say, forget that. Honestly, believe me, forget that. Because if you wait, that just causes more difficulty for you to get the sample. When a patient's in your surgery that day, just get a spot urine from them. We did some work that is published over a decade ago that showed if you collected the urine of proteinuric patients, the 24-hour urine, and took different aliquots, early morning, lunchtime, evening, the latter two, lunchtime and evening, were 99% correlated with the early morning one. Okay, and they all correlated with the total 24-hour output. So just pick any spot urine, and that will do. So I don't agree with that in NICE at all, because it just creates barriers for you. But anyway, you test it in diabetics, hypertensives, people with previous acute kidney injury, cardiovascular disease, if there's a known structural renal disease, multi-system disease such as lupus, gout, family history, incidental hematuria or proteinuria, and monitor the GFR annually in those patients taking medicines that can affect kidney function. Okay, and then here I'm not going to go through the whole guideline, but it's straightforward. If you've got proteinuria, and we come out the bottom here, if you've got repeated ACR greater than 3 or GFR less than 60, then you've got CKD. If the results are both above range, or sorry, below range for ACR, then it's not CKD. Okay, and you know the rest better than I do. So what's new is this. Okay, so I'm not sure if you know about this. So there's something called the kidney failure risk equation. So here it is here. The KFRE is what we're talking about. And this is how it was validated in a large study from the United States. And it is 4 variables. So in this equation, you don't have to do this, by the way. It'll be done for you, we hope. So it's age, gender, GFR, and urine ACR. 4 things. I mean, 4 things that you would routinely collect. Now, from that, the algorithm calculates what the 5-year risk of that patient developing end-stage kidney failure would be, and that's defined as a GFR of less than 15. Okay, which is stage 5 CKD. And the guidance from NICE now is that you will be hopefully you'll be told this from your local computer, that the 5-year risk is 3% or 10% or 20%, and the recommendation is that anyone with a 5-year risk of 5% or worse should be then referred into secondary care to the renal clinics. Okay, so that makes life just a bit easier than what we were told before. In diabetics, wait till their GFR is less than 30. Look at things like the rate of loss of GFR over time, and so on and so on. Just so it's trying to make things a bit easier for you, and that calculation will come. Okay, all right. So and also we're told in the renal community that we should make the discussion with patients a lot simpler. So instead of saying to them, oh, by the way, you've got a 5% risk of developing end-stage kidney failure in 5 years, what the hell does that mean to many people? So we'd say, in 5 years, 5 in 100 people with your condition, like you are, would be at risk of maybe needing to talk about dialysis. That's the sort of logic. But also we would be saying, but by the way, 95 people out of 100 won't. But if the risk is 50%, then obviously it's a totally different equation, saying, 50 out of 100 will have that risk, etc., etc. And then, so that is now part of the referral criteria into secondary care. So this kidney failure risk equation calculation, greater than a 5% risk over 5 years. Okay, it's calculated for you. And then these are some of the traditional things that are already in there, aren't they? That you know about. But this is a new one. And personally, I would really enjoy this a lot more, where we, instead of we're just seeing hundreds of patients, it'd be really nice to have almost like virtual meetings with you, where we could run through a whole series of cases and decide what the management should be. Quite quickly you could probably do that. And so virtual meetings are to be admired. I know in certain London hospitals they have virtual diabetic CKD clinics. For example, UCL, which is the Royal Free Hospital. In terms of goals of treatment in diabetic CKD, this is the way I look at it. I break it into 3 aspects. Clearly, as a kidney doctor, I'm very keen on the first, slowing or preventing nephropathy, and obviously the development of end-stage kidney disease, for the reasons I've said right at the beginning. Because when the lower down the GFR continuum they go towards end-stage kidney failure, the higher their risk. Anyway, so glycemic control is important. I'll show you some evidence. Blood pressure control is very important. Control of proteinuria goes hand in hand with blood pressure control. And then we've got some new evidence that has come through from this class of drugs that you're all familiar with, the dapagliflozin, canagliflozin, with the SGLT2 inhibitors. And I like GLP-1 agonists too, so liraglutide, semaglutide, because when you get to GFRs of 30 and below and you're stopping metformin, you're wondering, where do you go? Do you go straight onto insulin? Well, actually, this gives us another string to our bow, and I've used that quite a lot. And then we've got another therapy coming through that is just being licensed, and this stands for mineralocorticoid antagonists. So spironolactone is one of those, and there's a new drug called finerenone that has been trialed. It's made by Bayer, and that has been shown to be of benefit as well. I can talk about that at the end if you like. Improving quality of life. You do this really well, much better than I do. Lifestyle change, regular exercise with weight loss and fitness. We can help with anemia management. We've got EPO and intravenous iron, as you know, and then all of the above improves survival. But we mustn't forget cardiovascular management with statins. So just some targets for treatment, keeping things pragmatic. Glycemic control, we would aim, again, your targets will be, you'll know this better than me, but if we can get an HbA1c of 55 or less, that's really good diabetic control, isn't it? Given that diabetes is diagnosed at 48 and above. Blood pressure, let's be pragmatic, aiming for 130/80 if we can. Now, I wanted to spend another minute on proteinuria. Okay, so I'm getting some echo actually on, that's better, thanks. So proteinuria, we need to reduce this as low as we can. So first of all, people often ask, well, in hospitals you measure PCR, and yet in general practice we measure ACR. Well, yours is the more sensitive and accurate measure. Okay, so I'll give you an example. If we look at this one at the bottom, we all pass. This is a creatinine ratio, albumin to creatinine ratio, or protein to creatinine ratio. We all pass about 10 millimoles of creatinine every day. All of us do. All right. So if you multiply your UACR figure by 10, that gives you the amount of milligrams per day. So 70 is 700, and go back to the beginning, the cutoff is 3. So above 3, let's say 3.5, that's 35 milligrams a day of albumin, which is abnormal. Okay, so that's the way we interpret these. Now, roughly 2/3 of proteinuria in a diabetic will be albuminuria. Okay, so here you go. If the urine ACR is 70, their urine PCR will be about 100. So that's 70% of it, okay? So that's the way it works. So when I write back to you and say this person's UPCR is 100, then you can guarantee that their ACR is going to be somewhere between 60 and 70. Okay, that's the way we use it, and you can use those as a target for treatment as you improve your use of ACE inhibitors, ARBs, trying to get the proteinuria down. You can see that the ACR has fallen from like 61 one visit to 40 the next, and it genuinely does happen. And that's it's like improving the blood pressure. It's a good target to look at. So hemoglobin, if we're using EPO, we can only go up to 120 grams per litre. You probably know that. We shouldn't be pushing above that. Obviously, cholesterol targets, you know better than me. Obesity and exercise. Again, I'm not going to talk and tell grandmother how to suck eggs. So the advanced study, I just wanted to show some evidence that actually controlling glycemia is of benefit to kidney disease. So people have been skeptical in the past, but this study of 11,000 people with type 2 diabetes, they had intensive therapy, and this is old money for HbA1c, 6.5% versus not much difference, 7.3%, but literally in the intensively managed people, you've seen these forest plots before. So this favors the intensive management to the left, and you can see that new microalbuminuria and worsening nephropathy were improved by improving glucose control. So it does work, it is important. But you probably know that we've had very little new treatments at our disposal over the course of the last 20 years. And so there were 2 trials in 2001 that have really shaped everything that we've done for the 20 years thereafter. So we had something called the RENAL study with losartan and the IDMT study with irbesartan, so 2 angiotensin receptor blockers in type 2 diabetics with a gram of proteinuria, so really high risk, and their GFRs were under 60. And both of these drugs showed that there was something like a 20% risk reduction of people doubling their creatinine, getting end-stage kidney failure or death, a really important outcome. So based on that, we've just been shoving ACE inhibitors and ARBs at diabetics, but also all manner of kidney patients for 20 years. Glomerulonephritis, polycystic kidney disease. We've had no trials, so we've used this drug, we've extrapolated it without the evidence base because we're quite small in terms of patients available for those other trials. So we've only had that. So that's why it's been exciting to have new treatments, which I'm going to tell you about in a second. So I like this slide actually, and you'll be able to see this afterwards. It really summarizes how you treat diabetes, the 4 different ways. I really like it. So clearly, in people who need replacement of insulin, you give insulin. We can sensitize peripheral cells in people with insulin resistance to their own insulin without releasing any more, and that's what metformin does, and so do the glitazones. We can we can secrete more, so their pancreas is working, but we can bung out more insulin from the pancreas with secretagogues, they call them, don't they? So this is where your gliclazide comes in, sulfonylureas, the DPP4 inhibitors like the linagliptin, and the GLP-1 receptor agonists like liraglutide, semaglutide. So that's the secreting more insulin. And then we've got the latest group, which is excreting glucose in the urine, and that's the SGLT2 inhibitors. Okay, so that 4 different ways of managing glycemia. So let's tell you a tiny bit of the trial evidence. So the leader study was liraglutide. Okay, so before a prelude to this very quickly is that you probably know that when any new anti-diabetic medication is going to be licensed in the United States, the FDA, so this is their federal drugs agency that approves drugs, demand that drug has to be evaluated by a massive phase 3 cardiovascular outcome study. So that's called a CVOT, cardiovascular outcome study. And that's where all of these things that you've heard about, like the LEADER study, Canvas, things like that, all come from. EMPA-REG and things like that. They all came from that. And it came about because of the other glitazone. Do you remember the other, was it rosiglitazone? It basically was licensed in the United States, and then they found there were deaths occurring due to heart failure afterwards. So they now say, yes, we'll license your drug, but you've got to do the cardiovascular outcome study. Anyway, so the LEADER study was with liraglutide, and it was significant for its CVOT, so cardiovascular events look. It was much better, significantly better, as you can see. However, they also looked at secondary endpoints. So, not the main ones, secondary endpoints at kidney events. And this was, did they develop macroalbuminuria, that's dipstick positive, doubled the creatinine, etc., etc. And the answer was, it reduced the likelihood of that, liraglutide did, by 22%, which is really good. Now, what the mechanism behind that is, no one knows. The patients lose weight. You probably know that with the, well, you do know that with the GLP-1 agonists, because they're now used for weight loss, aren't they? Semaglutide it's got a license for it. But no one knows, blood pressure control was better as well. Anyway, I think they're quite a good class of drug. However, let's get on to the SGLT2 inhibitors. So again, these are the CVOT trials you might recall. And within those CVOTs, there were secondary endpoints, and then this is one of the secondary analyses, Canvas-R, and 40% GFR reduction or end-stage kidney failure was reduced by 40% compared to placebo. That, by the way, SOC is standard of care, isn't it? Canagliflozin standard of care. So in the cardiovascular specific trial, a secondary endpoint of improving kidney parameters was very, very good with this SGLT2 inhibitor. But most of it was in declining GFR, not end-stage kidney failure, because the patients were much earlier in their course than that. And if you compare the EMPA CVOT trial and the dapagliflozin CVOT trial, you've got similar data, almost the same looking for the same endpoints. Okay, so really good. All you can say is from those cardiovascular trials, there was a really good signal in all of them that these drugs were doing something good for the kidney disease. Okay, so what next? Well, of course, what next is we need renal specific trials, where the primary outcome is renal. And before I go on to those, just to show you why they might be of value for the kidneys. So basically, we filter 25,000 units. I love this story. 25,000 units of sodium, millimoles of sodium a day, which sounds, what the hell is he talking about? Sodium, it's boring as hell. However, that means that each hour we are chucking out into our urine 1,000 millimoles. Now just think about that. In your blood volume, we've got sodium at 140 millimoles per litre, 5 litres, that's 700 millimoles. So every hour I am throwing out into my urine 1.5 times my circulating sodium. So I have to reabsorb 99.9% of that. Otherwise, you wouldn't see me. I'd be lying on the floor giving you this talk, and I'll be hypotensive. So most of it's reabsorbed, and it's all reabsorbed in the proximal tubule via the sodium and glucose linked transporter. Okay, glucose goes with it. So glucose that we put into the urine, we all pass it in, gets reabsorbed back into our bloodstream with sodium. And don't forget, other sodium is reabsorbed in the thick ascending limb of the loop of Henle. So the loop diuretics, frusemide and bumetanide work there. And then thiazides work here in the distal tubule. And then we've got spironolactone and finerenone, eplerenone working in the collecting tubule as well. So what's the mechanism? So we block that sodium and glucose reabsorption here. So all of that stays in the urine and is excreted. Now, when the sodium at high concentration goes past the distal tubule, do you remember from medical school or from nursing, your BSc, that the macula densa were special cells around this area that will sense that high level of sodium, and they then feed back and cause constriction of the afferent arteriole. So it reduces the flow into the glomerulus. So what does that do? Well, you know that RAS blockade, so with ACE inhibitors and ARB, they dilate the efferent arteriole, so the pressure inside your glomerulus is reduced. And that's meant to be the benefit of all that we do and have done for the last 20 years, dropping the pressure in the glomeruli so they're less likely to damage, they're less likely to force out proteinuria. But what the SGLT2 inhibitors do, therefore, is by having that effect on the afferent arteriole going in, dropping the flow by this macula densa feedback, we call it tubuloglomerular feedback, then we're dropping the inflow as well. So we've got a double whammy, improving the outcome of our glomeruli. The problem is, as you know, with ACE inhibitors, is that we get an initial drop in GFR because of the ACE inhibitor mechanism, and we will get a drop in GFR associated with the dapagliflozin, canagliflozin as well, for the same reasons, and I'll show you that in a second. So very quickly on Credence. Credence was the first renal specific trial just in diabetics only, okay? And here they are. They had to be 30 years old or more. They had to have a GFR of 30 to 90. This is American units for albuminuria, so divide by 10, because 1 gram of creatinine is 10 millimoles. Okay, so that's 30 on your UACR up to 500, massive. That's 5 grams of albuminuria, and they had to be on maximum ACE or ARB. All right, and they had got canagliflozin 100, and obviously the licensed amount for treatment of glycemia is 300 versus placebo. Very interesting. I'm going to skip through this quickly. 63 years old. All hypertensive, diabetes that had for 16 years. Look, lots of them had cardiovascular disease at baseline, and that goes with their 16 years history of diabetes. 50%, look, and then these are the other drugs that they were on for their glycemic control. I won't go through this. Obviously, to get into the trial, you had to be on RAS inhibition, so 100% just about were. Just very quickly, if you look at this, GFR of less than 60, it was 60% of people. So 60% had stage 3 CKD or worse, okay? And then these are we won't dwell on the albuminuria, but the big albuminuria, average 900 milligrams per gram. So that's 90 urine ACR for us, 900 milligrams a day. And this is the main outcome of Credence. Look, this was published in 2019, April, and it showed a 30% reduction. Remember, this is a renal trial now, not a cardiovascular one. End-stage kidney failure, doubling of creatinine, renal death or cardiovascular death. And there was a 30% reduction. So big noise, okay? And if we look at something really serious, like how many developed kidney failure, then again, there was a major reduction, which has never been shown before by any trial. Okay, 32% hazard ratio of 6.68 is a 32% risk reduction. And so was it all driven by that HbA1c, getting the SGLT2 inhibitor? The answer is no. This is old money percentage. So the difference here at the beginning is what, 4 millimoles per mole, so tiddly. And at the end of the trial, it was only 2 millimoles per mole difference, so nothing. So it's not driven by HbA1c. It could be partly driven by systolic blood pressure, though, because the people getting the SGLT2 inhibitors were 3 millimeters on average less. And that doesn't sound a lot, but actually, when you look at antihypertensive trials, they're really delighted if you get a difference between the groups, between control and the new drug of 3 or 4 millimeters. So that could be important. Albuminuria dropped by 1/3 in the canagliflozin treated group. And this is something I need to point out. So there was, just like with ACE inhibitors and ARBs, there was an initial drop of about 4 or 5 mils per minute initially accompanying the drug. So we've got to, bite our lips and accept that, just like we do with ACE inhibitors and ARBs, because it's short-term pain for long-term gain with this. Look, because after the first initial period, the drop in GFR was much, much less per year than in the placebo group. Okay, so that's something to just, we can talk about that afterwards. And just to point out, compared to those CVOTs where the average GFR was 75 to 85, and the average amount of ACR was for you 1.2 to 1.8, so normal. So it didn't really have nephropathy. Credence was massively different. Look, they had a GFR of 56 and 900 ACR. Right, so DAPA-CKD is taking the world by storm. So this is the next SGLT2 inhibitor, a big study. Again, 4,000 in the Credence study. There was 4,000 odd, 4,300 in the DAPA-CKD. And in this is really interesting. A third of the patients did not have diabetes. So we had CKD with proteinuria. 2/3 were diabetic, 1/3 were not. Could you please turn off your mic, everyone? Thanks. Be really helpful. Thanks. Okay, so GFR 25 to 75, ACR. Now this is our money. Look, milligrams per millimole. So 22 to 565. So not dissimilar to Credence. Okay, and they all had to be on ACE inhibitors, and a similar composite primary endpoint of sustained 50% loss of GFR, end-stage kidney failure, renal. So slightly minimally different to Credence. I think Credence was 40%, wasn't it? Anyway, this is the primary outcome measure, a 39% reduction in the renal endpoint. Look at that, massive. Okay, and that's just over 2.5 years. And these are the diabetics, which was 2/3 of them, a 36% reduction in that endpoint, 0.64, and it was just the same or slightly better in those without diabetes. So this is really coming your way. In early CKD, even people are suggesting, even before you send to us, think about using dapagliflozin in people with, early degrees of albuminuria and, low GFR, maybe the hypertensives. We can talk about that afterwards. And in the interest of time, I'll whiz through this. So diabetes, yes, no. This is the famous forest plot. Everything's to the left in favor of dapagliflozin. Sorry about its name being a proprietary name kind of thing. GFR, look, it didn't matter whether it was low or high. It's worked that way. Albuminuria, low or high, it all was in the right direction. Okay, and even cardiovascular events were much, much better in the DAPA treated group. And there's been something called DAPA-HFs, dapagliflozin in heart failure. That's heart failure with reduced ejection fraction, systolic dysfunction, and with marked, similar benefits just in heart failure. So great drugs for heart failure and CKD. In terms of any risks in terms of safety, nothing really. So ketoacidosis is one thing we were warned about. No problems with that. And you'd think that with this drug, with major volume depletion, not particularly 6% versus 4%. And specific things like genital mycotic infection. Again, could people please just turn your mic off? It'd be very helpful. Microphones off. Be really helpful. Thanks. UTI. Again, very low. So if we're talking to our patients, less than 1% of the trials got a UTI. And the same as for Credence, this initial drop in GFR and then long-term gain. Okay, and so that's where we're up to. So these are the last two slides, then we can talk. The KDIGO, by the way, what is it? It's Kidney Disease Improving Global Outcomes. This is our international guideline group. Okay, so in 2019 it said that the initial stages of diabetic management in CKD should be SGLT2 inhibitors and metformin as first-line therapy together. Okay, right at the beginning. And the latest guidelines, you'll have seen this. So if you've got cardiovascular disease, high-risk patients, they should get an SGLT2 inhibitor with metformin. If they can't tolerate metformin, instead of metformin. And the same if they've got early CKD, those diabetics we don't see that you do, where their albuminuria is 5 and their GFR is greater than 60, they should be on an SGLT2 inhibitor. So they've got early heart failure, they should be on an SGLT2 inhibitor. So, okay. And then this is the penultimate slide. I like this. This is the 2022 KDIGO. And look, so it's a pyramid. Lifestyle goes for everyone. Diet, exercise, smoking, sensation, weight, that's good. First line drug therapy is metformin, SGLT2 inhibitors, RAS blockade, maximum tolerated, and statin, goes without saying. Then at the top, it's individualized, isn't it? Goal-directed therapy. So some people with heart disease might get aspirin or clopidogrel. I've told you briefly about the finerenone drug coming through. This is it's much more tolerated than spironolactone, so you get less hyperkalemia, etc. And then, where necessary, excuse me, liraglutide, semaglutide, and then things that you're good at: lipid management, glycemic control, and crucially blood pressure control. So that's all targeted for the individual patient. And that's the last slide, really, just to emphasize what I've said. So slowing of nephropathy, get the blood pressure down to less than 130/80. Use renin-angiotensin blockade to maximum tolerated, because that smashes the proteinuria. Weight loss, lifestyle, and that with blood pressure control will help control proteinuria. Glycemic control does matter, I've shown you that. But then we've got these new drugs that we should be using. And this is one for the future, really, coming in. It's not freely available yet in the UK, but you'll watch this space. You'll be hearing more from the autumn onwards about that, I'm sure. And then these are the other things that we can help together with you. All right, so look, that's me done. Let's I'll stop sharing and open up my screen, and delighted to, I think I've left around about 15 minutes for questions. So hope that helps. Thank you. Anyone like to ask any questions? Sunil? Hi, go ahead.
Sunil, do you want to ask a question?
You're on mute.
Yeah, sorry about that. Yeah,
sorry.
Thank you, Dr. Kala. Very informative presentation, and thank you for that. I just want some practical advice about the referral to the secondary care, where we should be doing it, because I think, great, we will work on everything what you mentioned, but when to refer? Like especially for diabetic patients, if they are having ACR of gradual increase from 30 to 40 to 50 to 60, where should we start thinking, no, it's not right, where we need to send them? Obviously, if something goes dramatically high, what should be the way for us to recheck? Is it something could be due to UTI? Is it something else could be causing a temporary increase? Like I can give an example of my patient, so that maybe we can put more things, and how to deal with the hypertensive who are having ACR high in comparison to diabetic patients. So is there a differentiation? Should we do something different?
So yeah, a few questions in there, really. So certainly, in terms of referring diabetics, anything that you're not comfortable really with. So if there's very, very high ACR to start with, just say it's in already 300, 400. Okay, then you might want to send those anyway. You'll try the initial steps. You try and maximize your ACE inhibitor, A or B. I by the way, I tend to use more A or B. I like irbesartan for some reason. Never mind. But you try and maximize those. Maybe add in the SGLT2 inhibitor. I think you should do that. But at 300, 400, 500 ACRs, we could be looking at something else. We could be dealing with a different type of nephropathy, and we might want to biopsy that kind of patient. Okay, so I'd agree with that. Otherwise, what about the ones where, despite your best efforts, things are increasing, like you just said, the ACR going 30, 40, 50, 60, then I think, provided you've done everything you can in terms of the right drugs, that means not controlling blood pressure just with amlodipine and doxazosin, but controlling it with maximum tolerated renin-angiotensin blockade, I call it. That's summarizing ACE and ARB. then, you know, and despite your SGLT2 inhibitors, then you could, I'm happy for those to come our way as well. Okay, maybe tracking those over a year or two. And then if they've got blood and protein together, by the way, that was something that was very briefly talked about in that nice slide, then they should come, because blood and protein, you probably know from when you did your examinations, certainly in the MRCP, blood and protein equals glomerulonephritis until proven otherwise, in the absence of UTI, of course. And then the third question was, what about hypertensives and ACR? Yeah, that's an interesting one. So hypertensive nephrosclerosis leading to albuminuria. Yeah, it is recognized. It's far more likely in people from African Black communities. That's well known, and that's something to do with some genetic background in the APOL1 gene that leads to earlier damage within the kidney. But in other patients, yeah, if you've got significant albuminuria, let's say an ACR of 50, in a patient who doesn't have diabetes, and you can't explain that, then we're interested in those patients, because that could easily be an early stage glomerulonephritis. What I would do is I would do the ultrasound scan, because you might just find you've got someone who's got prostatic disease with, you know, bladder outflow problems, or you might find they're actually someone with a scarred kidney. So if they've got chronic pyelonephritis, which is what scarring means, you know, they could have a past history of recurrent UTIs, you know, reflux in childhood, that kind of thing. So that might explain it. But if they've got normal kidneys on an ultrasound and proteinuria, and they're not diabetic, then we're interested in those, because we would biopsy them.
Like example for this patient, obviously by now listening to your presentation. So this is a 72-year-old lady. She is known diabetic and known hypertensive for at least 20 plus years. Her last ACR we did only in 2020. Obviously with COVID, she didn't do it and we couldn't get it. That's where the figure is 30%. And that was normal. And all of a sudden it was 319. I repeated it again, whether it was right thing or not, and they did PCR. That came back at 619. So if we take 30%, it's still around 400. Then I looked at blood pressure. It's well controlled. She's not on ARB. She's on Ramipril. Yeah, but maximum dose of Ramipril and blood pressure was controlled. She is on sitagliptin, not on dapagliflozin, but that's been going on for a long time. She is on metformin along with it, and she's on amlodipine also for blood pressure along with it. So clearly, I have made a referral already because the number was very high and it was a sudden jump. There was no urine in the, there was no blood in the urine. So I was not thinking in those lines. Patient is clinically well, nothing else is going on. So I made a referral. I'm not sure, you know, when she will get appointment, but are these kind of cases, should we be discussing with them?
That's an absolute classic that should come our way. No, but I mean, and especially the change in albuminuria like that, it might suggest she's got minimal change disease, you know, that has developed, you know, with the nephrotic syndrome. Has she got a low serum albumin, and has she got any edema? No?
Edema is not there. Her GFR is 89 and
Do you know what her albumin is, though? Serum
albumin is, I'm looking, 30.
So she's lost a lot. So that's significant. Okay. So that's heading, she's got the nephrotic syndrome almost by definition, without the edema. She's got nephrotic range proteinuria with a low albumin. Okay. So normal is 35 to 45 grams a litre of albumin. So she needs to be seen. She may well have a different type of nephritis.
Okay. Obviously, I made an urgent referral. I don't think she has got an appointment.
What I'd do is I would now swap that patient from the DPP4 inhibitor to the SGLT2 inhibitor. By the way, all of you, the DPP4s, I don't know what your belief is about them, but they've got no proper outcome data at all, other than that they're good at dropping the blood sugar. They have no cardiovascular outcome benefit and no renal outcome benefit. There's the only 3 drugs that save lives in terms of cardiovascular disease are metformin, SGLT2 inhibitors, and GLP-1 agonists. Okay. Any other questions at all? That was a really good one, Sunil. Thank you. Anup, I think you're muted as well.
Sorry, yeah, just just like for primary care.
Yeah.
So we say we've got like someone we've just like discovered diabetic type 2 and they've got like a raised ACR, and so first line obviously we start like an ACE or an ARB. And so when exactly do we like add an SGLT2? Do we titrate the ACE or ARB to maximum and then we add the other one? And the other question is like, do we still have to take into consideration EGFR when we add like a SGLT2? Because before there was all these things you can't start if EGFR is less than 60. Has that changed now? Because I think there's some like new guidance about like heart failure and stuff. So it can be started if your EGFR is less than 60. But what about in terms of like managing DKD? And the third thing, just any advice? Like sometimes we get like very elderly patients, like 82-year-old man, like type 2 diabetic for 20 years. Now ACR starting to go up. Like how do we manage them? Do we have to be as aggressive as what we would do for a 50-year-old? Like do we still like titrate to maximum? Do we still add the SGLT2? What would be your like opinion on this?
Okay, so there's a lot in there. So dealing with the first bit, and you may need to remind me about the last bit. The first bit is basically the cardiologists are really good at this. So they have a rule called 3 and 3. Okay, and by that they mean new heart failure comes in. So heart failure with reduced ejection fraction. Their aim is to get people onto an ACE inhibitor or ARB, onto a beta blocker, and now actually it's 4 and 4, mineralocorticoid antagonist, and DAPA, 4 and 4. And so they want DAPA obviously is a fixed dose 10, but the others are at lower doses, and they want those in 4 weeks. Okay, they don't want to mess around. 4 and 4 weeks is what they want to see. Now, I can tease this. My brother's a cardiologist in the south, and he's a heart failure specialist. Now, in CKD, this is where we're going. We're a bit more cautious, and we go for a 3 and 3, and that means 3 and 3 months, not 4 and 4 weeks. And so here we're talking. You're absolutely right. I think we should start the ACE inhibitor or ARB. Let's just go for your favorite drug, maybe Ramipril. Don't start at 1.25 in CKD. Start at 2.5 and ramp up to 5 after a couple of weeks. I would do. Let's not wait 6 months, a year and do it. Okay. And the other thing to say is I'll touch on all your points as we're going through. Rather than having to check the GFR at every stage, I don't believe that's necessary. I think it's after you started your 2.5 or 5, if there's not been a perceptible drop in GFR with that, then you don't need to check GFR at every step of the way, because I mean that wastes time and money as well, right? So that's another view. But I would then get them onto, it's a great question, I'd get them onto DAPA within sort of 3 or 4 weeks of initiating your ACE inhibitor or ARB, having checked the renal function. And again, the drug company SPC does not tell us to monitor the GFR, which surprises me. So I think I do in my patients. We've started lots of people on DAPA now. So I would start them. I would start the drug within 3 or 4 weeks of the ACE inhibitor or ARB, check function again at 2 to 3 weeks later. And then you can start thinking about ramping up your ACE inhibitor to maximum dose. Okay. Coming on to the elderly. So you said people 82, 84. Yeah, you're absolutely right. They were not in the trials, and but the likelihood is that they will benefit. And how tough do you need to be? We have to be cognizant of their blood pressure, don't we? We don't want to have them keeling over and causing a hip fracture. So I very, very much support that. So we've got to be very careful. But to an extent, yes, we should be trying to do the same thing. To an extent, but obviously, with the care that you give to the elderly, which I'm sure you'll be very good at.
Yeah, thanks very much.
Right, so we've got 2 or 3 minutes left. Any other questions from the assembled colleagues at all? Well, look, good luck with that KFRE. So the kidney failure risk equation, when that comes in, I'm hoping that you'll be getting a readout from the labs. I don't know when it'll be. It might be next year, but it'll be interesting. And you'll be. I'll give you, just before I finish, I'll give you some confidence here. So in Salford we've got something called the Salford Integrated Record, so we can actually see what goes on in primary care, and we looked at the 9,000 diabetics in Salford, that's the number, and looked at those who've got a KFRE of greater than 5%, right? So in other words, by the NICE guidance, should be referred into us. And there were 95 out of that 9,000, and 93 of those were known to us. So that's reassuring. So you've done it already, in other words. All right. So it's not going to be loads of extra work for you, but it's good for the future. So you've done it already, is the point. All right. Okay, great to see you all. Lovely. Thanks for the questions as well. Very good questions. All right. Cheers.
Thank you.
Thanks for that,
Thank you,
Cara.
Professor.
Thanks everyone for attending.
Thank you.
Bye-bye.
Thank you.
Bye.
Bye.